Thank you very much, Professor Oak. Very nice of you, and thank you again for inviting me to your meeting. Always a pleasure to be in Hanoi and to see a lot of senior colleagues here and esteemed colleagues. So today we kind of switch gears a little bit. We talk about endoleaks, which is something that I guess most of us don't talk about a lot, either because we are focused on doing the aortic stent graft well, or two, we usually pass it on to our interventional radiology colleagues, which is the other bit. I think some concepts in endoleak management that we need to kind of understand. Number one, the aorta is a dynamic organ. So the anatomy and the morphology continues to change even after you EVAR the patient. So what we are doing is introduce a rigid system into a dynamic organ during a stent graft repair. And so endoleaks can actually occur anytime after the EVAR. Sometimes we see them even 5 to 10 years post. Many people think that once you put the stent graft, there's no endoleak, they walk away from it. Number two, I think it's better to do a good EVAR than to get an endoleak. And what do I mean by that? I think nowadays we try and push limits. It's always very nice to show angulated necks, short necks, super short necks, and we have a lot of confidence in our new devices. And so we try and push the limit. We should be proactive in endoleak prevention and treatment during the actual surgery, and always consider, and I say this again many times, open aortic repair if you think there's a possibility of any difficult endoleak developing. Of course, this comes with experience, certainly with all the senior esteemed surgeons in this room, they know how to tell. And then if you have to repair an endoleak, you aim for a long-term seal and results rather than just plugging the leak for the moment. On table, at the end of it, you seal it, it looks very nice, but believe me, it comes back to haunt you, as we were discussing. And not all endoleaks can be managed with good endovascular techniques. Sometimes you may need to consider good old-fashioned open repair. So some concepts. Now we know that it occurs up to 25% of all stent graft cases, either immediately or on follow-up. The question we don't know is, and we debate all the time, is how long do we follow the patient up? 1 year, 2 years, 3 years, 5 years, 10 years? We do know that type 2 endoleaks are most common. I don't need to bore you with this, but basically this is the complicated classification of endoleaks from type 1A to 1C and the various types. We don't really see a lot of 4 and 5s nowadays unless you're looking at patients who are the first generation of stent grafts. But the question is really where is the problem and how you defined it during the operation. And one of the things about endoleaks is that you need to have good imaging available to detect it. And the earlier you detect it, even intraoperatively, the better. And so we use a lot of intra-arterial CT with a Dyna CT or Expert CT. I think gone are the days where you try and detect endoleak and try and operate with a C-arm. And what you really need to do is in a good hybrid theater. What do I mean? You can see on the left side, C-arm fluoroscopy image. On the right side, you can see the hybrid OT image. And clearly, there's a world of difference in how you detect the endoleak. Similarly, if you have an Expert CT, if you do a run, like if you see on the left, the patient looks like it doesn't have an endoleak, but if you do a Dyna CT or Expert CT, you can see that actually the patient has a type 1 endoleak posterior. So one of the key things to learn is the appearance of different types of endoleaks, but more importantly, we need to understand the hemodynamics of the flow leading to an endoleak, and that's crucial. For example, type 1, we know it's a high pressure and high flow. Type 2, we know it's a low flow and low pressure in most cases. Type 3, high flow and high pressure. And conversely, type 4 and 5, low flow and pressure. And so for us, we like to do intraoperative CT angios or multiple orthogonal views. And if we suspect after the surgery, we like to do a CTA early. Sometimes we use contrast-enhanced ultrasound. That helps a lot sometimes. So clearly you can see an immediate type 1A endoleak immediately after implant. And this is the corresponding CT on table. You can see that it's leaking quite significantly. So this is the advantage of having an Expert CT. Clearly, if it's a late detection, then most of us would do a routine CTA at 3, 6, 12 months, maybe an ultrasound to assess sex size, and perhaps a contrast-enhanced ultrasound. Sometimes I still use an old-fashioned angiogram or aortogram. I puncture the patient and I put a catheter up just to make sure that we don't miss anything, especially if the sac is increasing and we can't tell exactly where the leak is. So the current paradigm is type 1 and 3 endoleaks need to be treated as soon as possible. 2 endoleaks can mostly be followed up. 4 and 5 endoleaks rarely seen, but if you see it, you have to address it. So what are the various differences in how we do it? Clearly, we have a lot of tools and a lot of things we can do. Obviously, type 1 being you mold them, you extend them, you put a bare stent. Type 2, you do embolization. Type 3, you basically put another graft or you stent across the junctions of leaking. And type 4 and 5, basically you either reline them or you remove the graft. Open surgery-wise, also, you should be well familiarized as surgeons. If you have a type 1, some of us will choose to external bend the aneurysm sac or convert it. For type 2, we have been known to do laparoscopic ligation of the fetus, and then clearly 3 and 4, sometimes an open conversion. But right now, I think in the age of endovascular approach to it, if you can solve the problem without conversion, then this is the approach we use. So type 1 endoleaks, clearly a lot of it in the short term comes if you have a short neck or a very acute angulation, and in long term it happens when your graft migrates or your aorta gets ectatic. So your options are either you extend it, you chimney it, you fever it, or you embolize the leak. In a 1B, it's fairly straightforward. You embolize and you extend, or you convert it to a sandwich in the iliacs. So for example, in a severely angulated neck like this, we force a graft up. It looks very good initially, but as you can see, you mold a short landing zone, it works very well. Sometimes you still, after you mold and angulated, although it straightens the neck out, you can see a type 1 endoleak posteriorly. And in this sort of cases, where you are landing a little bit short, you try and extend a little bit more with another short cuff, and that usually does the trick. Sometimes it gets a little bit more complicated. You have an inverted funnel neck like this, and then of course, being confident in our devices, we try and squeeze a standard stand graft in a very angulated and horrible neck. And it looks very good. We land a little bit short. Obviously, on-table contrast enhanced ultrasound, you can see a huge leak there. And so there's a massive leak with a deficient coverage. And in this sort of case, we basically do a chimney extension, and then we put a cuff up. But still, you get a gutter leak. And in this sort of situation, I think Professor Cheng was talking about earlier, we basically embolize the leak point at that point in time. Certainly makes us feel good after the operation. We don't know how it works. It looks very good, and actually it sometimes lasts. This is another case where 1 year post-EVAR, you have a new type 2 endoleak, and of course we went in, I went in and translumbar embolized with the help of a radiologist under CT guidance, a type 2 endoleak. 6 months later, the patient came back for onset of pain, and then we found interestingly that there was a type 1A endoleak this time. For some reason, it had started to leak, and if you have this, so what we tried to do was try and do an extension. So we tried to do a triple chimney with an extension stenting up in this patient. And we had a lot of difficulty trying to advance some of the covered stents in. So in the end, we only managed to do the left, and then we molded. Clearly, the leak didn't resolve. 1 week later, we decided the best thing was to bring the patient back. And then we did a direct sac puncture, fill up the sac, coiled it, and basically embolized the whole sac completely. And this is 1 month post and 2 years post, still no leak, still doing well. And so these are some of the possibilities. Now I just want to talk about 1B endoleaks and the fact that a lot of us like to use large diameter flat limbs because this is almost standard armamentarium in our stand graft kit. So we talk about it all the time. And the idea of the large diameter cuff is that the flat end of the iliac limb extension can actually match or oversize the native common iliac artery diameter if it's enlarged. So the idea is that if you have a flat limb and you have a good seal, you will remove the pressure head against the aneurysmal wall. And then progressively, you should not have any more enlargement, and that should solve the problem. And it helps because it makes a case less complicated. You don't have to do an iliac branch graft. Typical case like this would be nice. So you have an iliac aneurysm as well on the right side, and you have the correct sizing of calf to native vessel diameter. Bear in mind the largest calf's now about 24. And ideally, you had a good wall apposition or parallel, sealing up to the iliac bifurcation, and good runoffs into the iliac arteries and the common femoral artery. So this is a typical case where you sit well, it looks well, and all ends well. And 1 year later, it still looks very well. And 2 years later, it still looks very well. However, sometimes even your flat limb can fail miserably. And this is a typical case where initially it came in, it was a contained leak, so we obviously wanted to save time, and so we thought this looked kind of good for a flat limb. It looks fairly aneurysmal in nature, but it looked like it matched, so we landed short quite clearly on the right side there, and thinking that that would work and that would solve the problem immediately. But clearly, 4 months post, patient leaked again, and it was clearly from the fact that the flat limb now had ruptured and didn't cover completely. And in this sort of case, we didn't select the patient very well, because if you look back at it, the limb didn't really match the aneurysm at all. And so in this case, we had to do an extension. We covered the internal iliac on this side, coiled it, and then we just extended it all as well. Type 2, most common type of leak seen up to 25% of cases due to back bleed from the mesenteric or lumbar arteries. Usually most resolve after 6 months, rarely lead to rupture. But the problem is trying to diagnose and trying to see where it is. And that's the irritating part, and trying to find it. So we usually, if we find that on the CT it doesn't work, sometimes we use a contrast enhanced to find the location of it. It can roughly tell you whether it's coming from the lumbus or coming from one of the iliac branches. And you can see when you do the initial run, it doesn't look very entertaining at all. But after the lumbus fill, then you see it filling up. That gives us a clue. And so we do a catheter-directed lumbar filling and then orthogonal view to just basically identify it. And once you identify it, if you can cannulate it, you cannulate it. If not, you do a direct puncture and you just fill it up with glue. Similarly, we like to do a trans-SMA approach. So we go through the SMA and we come all the way back down and find the back filling in, and then if possible, we glue it. Type 3, fairly straightforward. I think if you find a junctional leak, essentially what you do is you basically stent across it. But sometimes you need to master all your techniques and you learn and you need a combination. Example would be this patient, 83-year-old, AAA right iliac artery aneurysm, underwent a right iliac artery aneurysm coiling plus stent graft extension, had a type 1A, type 2 endoleak that they were not sure, and then it showed a type 1A. And the aneurysm was now 11 centimeters. As you can see, it's a huge aneurysm, and this guy is walking around with pain, and obviously nobody wanted to touch him because of his age. Now, how do you even approach a case like this? Because everywhere there are coils, everywhere they are leaking, and it continues down to the iliac. So you can see on the scan. And so what we did was we did the initial angiogram and decided where the leak was coming. We decided it was a massive type 1 from the top, coming and filling up the whole sac and coming down. And in this case, we basically got into the sac, coiled into the sac as a space filler first, and then we injected large amounts of glue to just fill up the rest of the sac and cause it to be thrombogenic in nature. But even then, it didn't work because it was still a top-end endoleak, and so we extended with the right renal chimney upwards, hopeful that that would solve the problem. Even then, it didn't work, so we still had another leak, and that's where we whipped out the endo stapler and said, well, this is the last-ditch attempt, all right? And it did. In the end, we stapled, we extended chimney, and we coiled everything. And it seemed to work very nicely, and 2 years later, he's still doing well. And of course, when all else fails, we go for an explant. And this is about the NICE surgery, neo-aortic system reconstruction. It's good operation. You have low infection rates, low graft thrombosis rates, non-thrombogenic, except that it's a prolonged operation. It's sometimes a bit technical. This is a 78-year-old male that we had. 2022 abdominal pain, EVAR 2022 with left IIA embolization. 2022 again had gas suggestive of infection. At that point in time, patient decided not for surgery. We gave antibiotics. Worked very well for 2 years, but he kept coming in with bacteremia, and finally it became a frank aortoduodenal fistula. And this sort of cases, I don't think there's a dispute that you need to really have no choice but to take it out. And so this is the classic CT. Basically, you have an infected graft, you have air bubbles, and it's stuck to your intestine. And in this case, essentially, we went in, and you can see the hole there. You can see the stent graft staring at you. We explanted the stent graft, and then we harvested his femoral vein, his superficial femoral vein, deep vein, and reconstructed the whole length of it into obviously a trouser graft, and then basically stitched it in. Looked fairly straightforward, but took us a bit of time because everything was stuck. A lot of people dispute about whether you should use the deep veins to reconstruct. I can tell you that yes, they will get some limb swelling, but it's fine. I think having saved a life, it's easier than to deal with limb swelling at the end of the day. And this is what the stent graft obviously looked like when it came out. So some key learning points. Early detection of endoleaks is important. Good imaging modality is very important, especially when you're doing the case. You need to be well-versed with different views. On-table Dyna CT or Expert CT is important. If you have contrast-enhanced ultrasound, I encourage you to use it. Sometimes you need to mix of both. Be mindful what is urgent to repair, type 1 and type 3, delayed maybe 2, 4, and 5. And you need to have the skill sets to deal with that. Either reduce stent grafting, chimney extension, fenestrated, embolization, but always at the back of your mind, always consider open repair in serial patients if you want good longevity. Thank you very much.